Good day, everyone. We are now going to talk about somatic symptom and related disorders. For the topic outline, this is the flow of this discussion. First, I am going to introduce to you the somatic symptom and related disorder, followed by its 3 out of 5 basic disorders listed in DSM5-TR, which are somatic symptom disorder, illness anxiety disorder, and psychological factors affecting other medical condition. The other 2 will be discussed by Ms. Hilario later. So, for the intended learning outcome after this report is that students should be able to identify somatic symptom and related disorders, then determine the diagnostic criteria, epidemiology, etiology, comorbidity, and treatment of somatic symptom disorder, illness anxiety disorder, and the psychological factors affecting other medical condition. And lastly, differentiate somatic symptom disorder, illness anxiety disorder, and psychological factors affecting other medical condition. Somatic symptom disorder and other disorders with prominent somatic symptoms constitutes a new category in DSM-5 called somatic symptom and related disorders. DSM-5 lists 5 basic somatic symptom and related disorders, which are somatic symptom disorder, illness anxiety disorder, psychological factors affecting other medical condition, conversion disorder, and factitious disorder. Having prominent somatic symptoms and or illness anxiety that causes serious suffering and functional impairment is a feature of all these disorders. In contrast to their more widespread occurrence in primary care and other medical settings, patients in psychiatric and other mental health care facilities are less likely to encounter people with disorders characterized by strong somatic symptoms or illness anxiety. So to understand the DSM-5 diagnosis, it's important to know why the somatic symptoms and related diagnosis changed from DSM-4. The term somatoform disorders in the DSM-4 was hard to understand, so it was changed to somatic symptom and related disorders. In DSM-4, there was a lot of overlap between the somatoform disorders, and the lines between diagnoses were not clear. Even though people with these disorders usually show up in medical rather than mental health settings, non-psychiatric doctors found it hard to understand and use the DSM-4 somatoform diagnosis. The present DSM-5 classification takes this into account by cutting down on both the number of disorders and the number of subcategories for each disorder. If you look at the table I made, you will see that in DSM-4, it has the somatization disorder, hypochondriasis, pain disorder, and differentiated somatoform disorder, conversion disorder, and body dysmorphic disorder. Now, in DSM-5, somatoform disorder became somatic symptom and related disorders. It has somatic symptom disorders, illness anxiety disorder, conversion disorder, psychological factors affecting other medical condition, factitious disorder, and other specific and non-specific somatic symptom disorders. In comparison, DSM-5 eliminated the diagnosis of somatization disorder, hypochondriasis, pain disorder, and undifferentiated somatoform disorder. Most of the patients who previously received this diagnosis are now diagnosed in DSM-5 with somatic symptom disorder. The hypochondriasis is now also diagnosed as illness anxiety disorder. Then the conversion disorder, it remains in the DSM-5, and in addition, the DSM-5 now has the factitious disorder and other specific and non-specific somatic symptom disorders. So where did body dysmorphic disorder go? Body dysmorphic disorder is now classified in the chapter of obsessive compulsive and related disorders along with the OCD and several other disorders. The DSM-4 criteria put too much weight on the fact that symptoms couldn't be explained by known pathophysiological processes. There are different levels of these symptoms, especially in functional neurological symptom disorder, but the but the somatic symptom disorders can also occur with known medical conditions. So it's not easy to say that a somatic symptom cannot be explained by a known pathophysiological process related to a known medical condition. And basing a diagnosis on the lack of an explanation is problematic and reinforces the idea that the mind and body are separate. A person shouldn't be given a mental disorder diagnosis just because they can't show they have a known medical condition. Also, having a known medical condition doesn't rule out having a mental disorder at the same time, including a somatic symptom and related disorder. People may have thought that these diagnoses were pejorative and demeaning because DSM-4 focused so much on the lack of a medical explanation. And this made it sound like their physical symptoms were not real. And somatic symptoms disorder is the main diagnosis in the DSM-5, which is based on the positive symptoms, like the distressing somatic symptoms plus abnormal thoughts, feelings, and behaviors in response to these symptoms, and in functional neurological symptom disorder and pseudocyesis or other specified somatic symptom and related disorder. The focus is on showing clinical evidence of incompatibility with known pathophysiological processes. Let's proceed to the 5 basic somatic symptom and related disorders. And the first one is somatic symptom disorder. So, somatic. Okay, I've been mentioning it a few times now, and maybe some of us may not know or not really know it, or maybe not familiar with it. So, somatic is basically means relating to the body or the physical body. So in simple terms, somatic symptom disorder will be all about the physical symptoms, or it is the physical symptom disorder. So this disorder is previously called the Briquet syndrome because in 1859, Pierre Briquet, a French physician, described patients who came to see him with seemingly endless list of somatic complaints for which he could not find any medical basis. So, despite his negative findings, the patients they keep on coming back, and with either the same complaints or new list containing slightly new variations from the old complaints of theirs. So for many years, this disorder was called Briquet syndrome, and in DSM-4 it was called somatoform disorder, but now would be considered somatic symptom disorder. This disorder is where psychological condition involving somatic symptoms are distressing and cause significant dysfunction in daily life. Somatic symptoms are bodily symptoms, so maybe there could be pain in the arm or pain in the leg that doesn't seem to be caused by an underlying organic condition. It appears to be related to psychological condition. Oftentimes, patients believe that the symptom or symptoms are indicative of a serious underlying disease or disorder. It may be related to increased sensitivity to bodily sensations, and so this may be simply because that the patient may be more sensitive to certain somatic stimuli. Now, for the signs and symptoms and how this disorder is diagnosed via the DSM-5 criteria. The criterion A of the DSM-5 criteria states that the patient must have one or more somatic symptoms or bodily symptoms that are distressing or result in significant disruption of daily life. So they may find that they cannot think of anything else except that the symptom, it may cause them to miss work, impact their relationships, or lessen their performance. This type of disruption in life would be required to say that the criterion A is met. That is not the only criterion that we have to meet, but we have to at least have it progress to criterion B, where excessive thoughts, feelings, or behaviors related to the somatic symptoms or associated with health concerns as manifested by at least one of the following: the disproportionate and persistent thoughts about the seriousness of one's symptoms, the persistently high level of anxiety about health or symptoms, and the excessive time and energy devoted to those symptoms or health concerns. Again, as you can see, they at least have to have a very significant somatic symptom, at least one that impacts their life. They overthink about the symptoms, they have anxiety because of it, and spend time and energy to check their overall health. That would meet the criterion B. So in this, the criterion C is that although any one somatic symptom may not be continuously present, the state of being symptomatic is persistent for at least 6 months. So this is the time requirement for this condition or disorder. This means that they must have somatic symptom that meets criterion A and B for at least 6 months. So they at least have to have a somatic symptom that would last for at least 6 months. It does not need to be the same symptom. They could have their arm hurt for let's say 3 months, and that goes away, and then the foot is hurting for another 3 months, and that would be enough to meet the criterion C. If they met those criteria, that would be enough to say that they have the diagnosis of somatic symptom disorder. But there are certain specifiers that can go along with this condition, and one of them is with predominant pain. If somatic symptom is predominantly in pain, then persistent would indicate that there are severe symptoms causing significant impairment and lasting more than 6 months. And there are certain levels of severity. So mild somatic symptom disorder is where only one criterion B symptom is met. Moderate would be 2 or more of the criterion B symptoms are met. And in severe is where there are 2 or more of criterion B symptoms are met, but there are more somatic symptoms involved. So in severe somatic symptoms disorder, the impairment is very noticeable, and if the disorder is persistent, it can cause invalidism. Now, the prevalence of this disorder is unclear, but there are estimates from the limited epidemiological literature on DSM5-TR somatoform disorders. In the more recent population-based studies with a questionnaire-based strategy using the DSM-5 diagnostic criteria for the somatic symptom disorder in adult and adolescent samples, report prevalence rates between the 6.7% and 17.4%. And based on research conducted in Europe and North America, the prevalence of somatic symptom disorder in the general adult population can be approximated as 4% to 6%. However, overall estimates of somatic symptom disorder are around 5 to 7% according to APA in the year 2013. With this, it was also that women tend to report more somatic symptoms than do men, and the prevalence of somatic symptom disorder is consequently likely to be higher in women. For the etiology or the cause of somatic symptom disorder, we have factors coming from neurobiological, cognitive behavioral, and theories on psychodynamic, cognitive, behavioral, and sociocultural. This etiology, I got it or based it on the Abnormal Psychology 2nd edition and the 12th edition. The neurobiological models of somatic symptom disorders focus on the parts of the brain that are turned on when unpleasant body sensations happen. The anterior insula and anterior cingulate are 2 parts of the brain that become more active when a person feels pain or something uncomfortable, like heat. These parts of the brain have strong links to the somatosensory cortex, which is a part of the brain that processes body sensations. When activity is higher in these areas, people are more likely to have somatic symptoms and rate a standard painful stimulus as being more unpleasant. So, Some people may have overactive parts of the brain that help them judge how unpleasant the body sensations are. This could help explain why they are more uh, they are more likely to have somatic symptoms and notice pain. It is well known that anxiety, depression, and stress hormones can all make pain and other somatic symptoms worse. Activity in the anterior cingulate is also linked to depression and anxiety. So the anterior cingulate and the anterior insula can also be activated by emotional pain such as remembering the end of a relationship or having breakup. The fact that these parts of the brain are involved in both physical and emotional pain may help explain why emotions and depression can make pain feel worse. So like the neurobiological models of somatic symptom disorders, cognitive behavioral models uh, try to figure out what causes people to think too much about their health and feel anxious about it. Once a somatic symptom shows up, it seems that paying attention to body sensations and figuring out what those sensations mean are very important. Researchers have used a version of the emotion Stroop task to study how people pay attention to health cues. So patients with somatoform disorder, major depressive disorder, or panic disorder, as diagnosed by the DSM-4-TR, they were asked to name the color of the words as quickly as possible while ignoring the words themselves. So a lot of the words had to do with health and sickness. And patients with somatoform disorder had more trouble ignoring words about physical health than other words. Meanwhile, the other patients, they did not have this problem. So people who worry too much about their physical symptoms may automatically pay attention to signs of physical health problems. People who worry a lot about their health also have an attributional style in which they think the worst of their physical symptoms. A person's idea of why something is happening is what they call an attribution. These specifics could be different. So one person might think that a red spot on the skin means they have cancer. Someone else might think that a symptom is a sign of a disease more often than it really is. So they may think too much about those symptoms, maybe even small signs that they are not. They're making it more of a big deal when they shouldn't be not. So the cognitive bias can take different shapes, but once negative thoughts starts to come up, the resulting rises in anxiety and cortisol may make somatic symptoms and distress over those symptoms worse. Fear that a bodily feeling means you are sick is likely to make you do the two things. First, the person may act like they are sick and avoid work and social activities. This can make symptoms worse because it makes it harder to exercise and do other healthy things. Second, the person may try to get reassurance from doctors and family members. This behavior of looking for help may be reinforced if it gets the person attention or sympathy. So this will be explained further by the next or other theories. With this, according to the psychodynamic theory, the somatic symptoms manifest as a reaction to unconscious emotional disorders. The somatic symptoms are caused and maintained by two factors: the primary gain and secondary gain. Internal motivators are produced by primary gains, whereas the external motivators are produced by the secondary gains. So, internal ang primary, nasa labas or external naman ang secondary. When it comes to somatic disorders, psychodynamic theorists believe that the major gain is protection from anxiety or emotional symptoms and or conflicts. This urge for protection manifests as a physical symptoms such as pain, headache, and so on. The secondary gain or the external experiences that result from the physical symptoms that keep these physical symptoms going might range from attention and sympathy to missed work, financial aid, or psychiatric incapacity, and to name a few. Somatic disorders, according to the cognitive theories, are caused by negative attitudes or exaggerated fears about the physiological sensations. Individuals suffering from somatic disorders may be more sensitive to body sensations. Individuals with this sensitivity, along with the maladaptive mental process, they may overanalyze and interpret the what they call this. They may interpret their physiological symptoms negatively. Example given was that a person suffering from a headache may exaggerate their symptoms and assume that their headache is the direct result of a brain tumor rather than stress or other inoculate causes. So, when their physician does not confirm this diagnosis, the individual may become even more anxious, believing that they have an incredibly unusual condition that it necessitates a specialist evaluation. In line with the behavioral approach to mental disorders, behaviorists, on the other hand, believe that reinforcers cause and keep the somatic disorders going. So more specifically, people who have a lot of physical symptoms are often rewarded by the attention they get from other people. These rewards could also be given for more important things like getting disability. And even though the behavioral theory of somatic disorders seems to be similar to the psychodynamic theory of secondary gains, there is a clear difference between the two. The behaviorists, they see these gains as the main reason for the development and maintenance of the disorder, while the psychodynamic theorists see them as a result of the underlying conflicts that cause the disorder. The sociocultural factors can play a role in the somatic disorders in a couple of different ways. First, there is the social factor of family influence, which probably has a big effect on how much people pay attention to their physical symptoms. People with somatic symptoms disorder are more likely to have a family member or close friend who pays too much attention to their somatic symptoms or who has a high anxiety about their health. Another sociocultural factor is that Western countries focus less on somatic symptoms compared than the Eastern countries. Different perceptions of mind-body relationships may explain this. Easterners focus more on the mind-body interaction and how psychological and somatic disorders interact. The Asian folks are more prone to report physical stress symptoms than cognitive or emotional issues. The development and course of somatic symptom disorder begins as early as childhood and or usually begins by age 30. The course of somatic symptom disorder is likely to be chronic and fluctuating and influenced by the number of symptoms, individual's age, level of impairment, and any comorbidity. The children, they commonly experience stomach pain, headaches, tiredness, and feeling sick. Children have more major symptoms than adults. When diagnosing a younger person, remember, it's crucial to collect patient, family, and other assessments like school about symptoms. How parents comprehend and react to their child's symptoms might affect distress, medical testing and treatments, and school absences. In older people, multi-regional pain is most common. Age promotes multimorbidity and somatic symptoms. Somatic symptom disorder prevalence may decline after age 65. In older adults, excessive thoughts, sentiments, or behaviors connected to somatic symptoms or health worries are required for diagnosis. Somatic symptom disorder may be underdiagnosed in older adults because the certain somatic symptom are or they are considered typical aging, or because disease worry is understandable in older persons with more general medical illnesses and medications than younger people. For the factors relating to the risk and predictions of the disorder, a large variety of somatic symptoms has been linked to the personality trait of negative affectivity, also known as neuroticism, which has been found as an independent correlate and risk factor for the condition. It is typical for people to suffer from both anxiety and depression at the same time, which can make symptoms and impairment worse. The environmental factor plays a role in the development of somatic symptom disorder, which is more common in people who have a lower level of education, a lower socioeconomic standing, and who have recently been through traumatic or health-related life events. It is also possible that early adversity in one's lifetime, such as being sexually abused as a child, is a risk factor for somatic symptom disorder in adults. Persistent somatic symptoms are linked to demographic factors too, such as women, older age, less education, lower socioeconomic status, unemployment, a history of sexual abuse or other childhood adversity, concurrent chronic physical illness or mental disorder, social stress, and reinforcing social factors such as illness, benefits. Somatic symptom severity is linked to female gender, anxiety, depression, and overall illness. Sensitization to pain, heightened attention to body sensations, and attribution of bodily symptoms to a possible medical condition alter clinical progress. Somatic symptom disorder is comorbid with many mental and physical illnesses. Anxiety and depression co-occur in up to 50% of the somatic symptom problems and severely impair function and quality of life. The somatic symptom disorder often co-occur with, take note, PTSD and OCD. Men's sexual dysfunction is also linked. There is also high comorbidity between the somatic disorders and other physical disorders classified as central sensitivity syndromes or CSS due to their common central sensitization symptoms, yet medically unexplained symptoms. People who have these disorders often find it hard to get help because they think that their problems are all medical and don't think they need psychological help. When a person has seen several doctors and still doesn't feel better, that's the time that they usually agree to try psychotherapy, psychopharmacology, or both. The biopsychosocial model helps primary care doctors understand how the biological and psychological parts of an illness interact with each other. This helps improve the relationship between clinicians and their patients, as well as multidisciplinary approaches to caring for patients. So biopsychosocial model encourages the clinician to try to explain things by looking at all the biological, psychological, and social factors that could be causing or keeping the disorder going. So, most of the time, this kind of treatment is done through a multidisciplinary approach in which the symptoms are taken care of by a number of professionals. Usually, there is a doctor, a psychiatrist, and a psychologist. They work together. So, the interdisciplinary approach provides a higher level of care because experts from different fields work together to come up with a treatment goal. Even though this method is harder to find, especially in more rural areas, it is thought to be more effective because all of the healthcare providers are working together to treat the patient in the same way. Now, the goal of treating the somatic symptom disorder is to control both the physical and mental symptoms. This is done with psychotherapy and sometimes with medication that treat anxiety and depression that are causing the disorder. So, cognitive behavioral therapy, or the CBT, is a type of psychotherapy that helps people learn how to change their ways of thinking or acting to change how they feel. CBT, or the cognitive behavioral therapy, when done with the help of a psychologist or psychiatrist, it helps people deal with the anxiety and stress better and respond better to situations. So, the CBT can help people with the somatic symptom disorder to think about how they feel and what they think about their symptoms and their health in general. Next, it also helps people find ways to worry less about their symptoms and stress less, to stop thinking so much about how they feel, to figure out what seems to make their health problems worse, and even if they still have pain or other symptoms, find ways to stay active and social and to do better in their everyday life. The next treatment would be the mindfulness cognitive therapy, which is built on the idea of cognitive therapy. Techniques like mindfulness meditation are used to teach people to be aware of their thoughts and feelings without judging them. As part of the mindfulness-based cognitive therapy, or MBCT, or commonly known as mindfulness cognitive therapy, or MCT, a number of exercises and techniques that help people be more mindful are used. Meditation, the body scan exercise, mindfulness practices, mindfulness stretching, and yoga are some of these mindfulness-based cognitive therapy. So it uses parts of cognitive therapy to help the individual recognize and rethink their negative thought patterns and replace them with more realistic, positive thoughts. The next one is the family therapy. This is a type of treatment that helps with problems that affect the mental health and functioning of the whole family. It can help family members get along better with each other, talk to each other better, and deal with conflicts in the family system. Family therapy can help close relationships change by making it easier for family members to talk to and get along with each other. Some of the main goals of family therapy are to make the home a better place, solve family problems, and learn about the unique problems each family faces. This kind of therapy also looks at how family members can help a family member who is having trouble. For example, if one person in the family has a mental health problem, family therapy can help change some things that can sometimes make the problem worse. Now, for the pharmacological interventions, it wasn't used very often because they might have side effects and their effectiveness isn't well known. Since these people already react more strongly to their physical symptoms, it is likely that the side effects of medication would hurt them more than they would help. So, the psychopharmacological interventions may be helpful for people who have more than one mental disorder, like depression or anxiety, which make it hard for them to do psychotherapy. The most common used medication are antidepressants, such as tofranil or imipramine in other name, and the citalopram or the Celexa. The next disorder is illness anxiety disorder. Illness anxiety disorder was formerly known as hypochondriasis, which is still the term widely used among the public. In illness anxiety disorder, as we know it today, physical symptoms are either not experienced at the present time or are very mild, but severe anxiety is focused on the possibility of having or developing a serious disease. Illness anxiety disorder is a mental illness in which a person worries about getting or already having a serious undiagnosed medical illness. Either there are no somatic symptoms or they are mild. Illness anxiety is a type of generalized anxiety disorder that is only worried about their health. So it is diagnosed when individuals perform excessive health-related behaviors such as checking their body, lifestyle alterations, and research, or exhibits maladaptive avoidance of medical care. So they may be, the patient or the individual may be all in and trying to figure out what it is, or they may be all out in trying to keep it themselves and refuse to seek medical opinion. Now, the signs and symptoms and how this condition is diagnosed via DSM-5 criteria. Criterion A states that the patient fears of getting or already having a serious undiagnosed medical condition. In Criterion B, it states that there are no somatic symptoms, or if there are any, they are mild. And if there is another medical problem or a high chance of getting a medical problem, for example, if there is a strong family history of medical problems, the worry is clearly too much or out of proportion. To progress in Criterion C, an individual is obsessed with the idea that they are sick. They worry a lot about their health and disease. So there is a lot of worry about the health, and the person is easily worried about his or her own health. Therefore, this disorder becomes a big part of a person's identity and self-image, a common topic of conversation, and a typical way to deal with stressful events in life. People with this disorder often look at themselves over and over. This is where Criterion D comes in. Criterion D states that the individual performs excessive health-related behaviors or exhibits maladaptive avoidance. They do too much research on the disease they think they might like surfing the internet for what are the symptoms of mga ganong way or ganong behavior na pag-search, or what is the meaning of having too much headache, what kind of disease has throbbing arm, what does it means when your foot swells, mga ganong kind ng pag-search sa internet. And keep asking family, friends, or doctors for reassurance. This constant worrying is often annoying to other people and can cause a lot of stress in the family. In some cases, anxiety makes people avoid situations like going to see a sick family member, or activities like going to the gym that they think might hurt their health. So for the Criterion E, illness preoccupation has been present for at least 6 months, but the specific illness that is feared may change over that period of time. This is the time requirement for this condition or disorder. So in Criterion F, it states that the illness-related preoccupation is not better explained by another mental disorder like somatic symptom disorder, panic disorder, generalized anxiety disorder, body dysmorphic disorder, obsessive-compulsive disorder, or somatic delusional disorder. If they met those criteria, that would be enough to say that they have the diagnosis of illness anxiety disorder. But there is also certain specifier of what type a patient is that can go along with this condition, and one of them is with care-seeking type. So, care-seeking type is where medical care, including physician visits or undergoing tests and procedures is frequently used. Therefore, the care-seeking type patients are those individuals who seeks medical opinion or frequently visits the hospital. Meanwhile, the care avoidant type is where medical care is rarely used. So this type of patient they avoid medical consultation or does not believe in being helped by health care professionals. For the prevalence, hypochondriasis and health anxiety from the DSM-3 and DSM-4 are used to estimate the number of people with illness anxiety disorder. In a study of patients in specialty clinics, about 20% of individuals reported illness anxiety. Community surveys and population-based samples from high-income countries like the United States and Germany show that between 1.3% and 10% of people have health anxiety and or believe that they have a disease for at least 1 to 2 years. In the ambulatory medical population from different countries, the 6-month to 1-year prevalence rates range from 2.2% to 8%, with the weighted mean prevalence rate of 3%. Seeing as the illness anxiety disorder is a newer diagnosis, the prevalence rates are largely based on the previous disorder, as what I've mentioned before, and the previous findings suggest that illness anxiety disorder occurs in the 1 to 10% of the general population and is equal among males and females. For the etiology or the cause of illness anxiety disorder, we also have factors coming from age, stress, other disorders and symptoms, trauma in early life, and medical background and family history. The exact cause of illness anxiety disorder is still mostly an unknown, but these are the general and common factors. Age. Although the first symptoms of illness anxiety disorder can arise at any time, most people experience them between the ages of 25 and 35, and anxiety disorders related to illness may worsen with age. People with illness anxiety disorder may feel uneasy when they have normal body sensations, and they may think that small changes in their bodies are wrong. Life's major stresses, such as a loved one's death, might trigger or exacerbate the onset of sickness anxiety disorder symptoms. So stress is also a factor or a cause of illness anxiety disorder. Other disorders and symptoms. Illness anxiety disorder may be more likely to develop when a person experiences a potential life-threatening symptom such as chest pain. Illness anxiety disorder is more likely to develop in those who have a history of depression, anxiety, or psychotic disorders. Trauma in early life. History of recurrent or severe childhood sickness, as well as a history of physical, sexual, or emotional child abuse or neglect, appear to be risk factors for illness anxiety disorder. Medical background and family history. One possible risk factor for developing sickness anxiety disorder is having a first-degree relative with a disorder. This is generally attributed to the children's practice of observational learning, in which they learn via observing, memorizing, and imitating the acts of trusted adults. Disease anxiety disorder is more likely to occur in those who have either a personal or the family history of chronic or serious illness, or who have previous negative experiences with the healthcare system or healthcare practitioners. Illness anxiety disorder can happen if a person grows up in a family where health worries are often talked about, or if their parents worry too much about their health. Also, if a person spends a lot of time looking at health-related information on the internet, he or she may be more likely to get illness anxiety disorder. As for its development and course, it's not clear how illness anxiety disorder starts or how it will progress. Most people think that illness anxiety disorder is a long-term, episodic, and relapsing illness that starts between early and middle adulthood. It is thought that the disorder is rare in children, but health-related anxiety can start in childhood or adolescence. In some population-based samples, anxiety about health goes up with age, but in others, it peaks in middle age and goes down as people get older. People with high health anxiety in medical settings don't seem to be any younger or older than other people in those settings. When older people worry about their health, they often worry about losing their memories and senses. The risk and predictive factors of illness anxiety disorder is mainly observed or coming from the environment of a patient. Illness anxiety disorder can sometimes be caused by a major stress in a person's life or a serious but harmless threat to his or her health. A history of abuse or a serious illness as a child, a serious illness in a parent, or the death of a sick parent during childhood may make a person more likely to develop the disorder as an adult. As for the comorbidity of illness anxiety disorder, it happens along with the generalized anxiety disorder, panic disorder, obsessive compulsive disorder, and depressive disorders. About two-thirds of people with illness anxiety disorder also have at least one other major mental disorder at the same time. While there is not a lot of information regarding specific comorbidities among somatic-related disorders, there is some evidence to suggest that those with illness anxiety disorders are at risk of developing somatic symptom and personality disorders according to the APA in year 2013. The treatment of illness anxiety disorder is almost the same as the treatments in somatic symptom disorder. The biopsychosocial model helps doctors understand how biological and psychological aspects of sickness interact, and this improves clinician-patient relationships and multidisciplinary care. The biopsychosocial paradigm urges physicians to look at biological, psychological, and social components that could cause or maintain the condition. Usually, a doctor, a psychiatrist, and a psychologist work together to address these symptoms. Interdisciplinary care is better because professionals from different fields collaborate on a treatment goal, and this strategy is may be difficult to be found in rural areas, but it is regarded to be more effective because all the healthcare providers work together to treat the patient. When treating illness anxiety disorder, the goals are to return things to as close to normal as possible and keep them way, relieve mental distress and or prevent the overuse of the medical system and resources. Psychotherapy and sometimes antidepressants are used to treat the illness. Again, CBT or cognitive behavioral therapy helps people adjust their thinking and behavior to improve how they feel. It helps people deal with anxiety, stress, and circumstances when done with a psychologist or psychiatrist. It helps the patient with somatic symptom disorder to think about how they feel and what they think about their symptoms and their health in general, find ways to worry less about their symptoms and stress less, stop thinking so much about how they feel, figure out what seems to make their health problem worse, even if they still have pain or other symptoms, find ways to stay active and social, and lastly, to do better in their everyday life. Next treatment is that mindfulness meditation helps people recognize their thoughts and feelings without judgment. It uses exercises and approaches to increase mindfulness. Meditation, body scan, mindfulness practices, mindfulness stretching, and yoga, again, are some of its practices or therapies used in this treatment. So it employs cognitive therapy to help them or help individual with the illness anxiety disorder identify and rethink problematic thought habits. Next one is the family therapy support, or the family therapy that supports mental health and family functioning. It helps family members get along, communicate, and resolve issues. Family therapy can improve relationships by helping family members communicate and get along, and aims to improve the home, solve family problems, and identify each family's specific issues. This therapy examines how family members can support a struggling member and can help change things that can make a mental health problem worse. For example, people with illness anxiety disorder often benefit from medication too, especially if they have other mental health problems like, as I've mentioned in the comorbidity, like OCD, depression, or generalized anxiety disorder. Most of the time, antidepressants like selective serotonin reuptake inhibitors or SSRIs, which raise serotonin levels in the brain, are given to people with illness anxiety disorder. The most common medicines prescribed to people with illness anxiety disorder are tofranil or imipramine, citalopram or Celexa, and fluoxetine or Prozac, or the other term is Sarafem. Now, moving on to the psychological factors affecting other medical condition. Psychological factors affecting other medical conditions is as a physical disorder identified when psychological or behavioral factors adversely affect a person's medical condition and raise the risk of for pain, death, or impairment. Psychological discomfort, interpersonal patterns, coping styles, and maladaptive health behaviors such as denial of symptoms or poor adherence to medical recommendations are few of its factors. This disorder is different than all the previously mentioned somatic-related disorders, as the primary focus of the disorder is not the mental disorder but rather the physical disorder. In signs and symptoms and how this condition is diagnosed via DSM-5 criteria, the criteria A states that a medical symptom or condition is present. So it means that other than a mental disorder, other symptoms or condition must exist. Criterion B states that the most important thing about psychological factors affecting other medical conditions is the presence of one or more clinically significant psychological or behavioral factors that make a medical condition worse by increasing the risk of pain, death, or disability. These things can make the medical condition worse by changing its course or treatment, by adding a well-known health risk factor, or by changing the underlying pathophysiology in a way that causes or worsens symptoms or make medical help necessary. Psychological or behavioral factors include psychological distress, patterns of interactions with others, coping styles, and unhealthy health behaviors like denying the symptoms or not following the doctor's orders. In progression, criterion C states that the psychological and behavioral factors in criterion B are not better explained by another mental disorder. Hence, panic disorder, major depressive order, or post-traumatic stress disorder cannot explain criterion B's psychological and behavioral aspect. Similar to somatic symptom disorder, if met with those criteria, that would be enough to say they have the diagnosis of psychological factors affecting medical condition, but there is certain specifier that can go along with this condition, and these are mild, moderate, severe, and extreme. Mild can increase medical risk, such as not taking blood pressure medicine as prescribed. Moderate is where it makes a health problem worse, and severe is where the person needs to be hospitalized or goes to the emergency room. And lastly, extreme puts an individual's life in grave danger and this may sometimes lead to death. The prevalence of psychological factors affecting other medical conditions is also unclear, but thought to be more common than most somatic symptom disorders. It's not clear how often psychological factors cause or worsen other medical conditions. Based on data from the private insurance billing in the United States, it was a more common diagnosis than somatic symptom disorders in the DSM-4. So there are also little data or information on the prevalence of psychological factors affecting other medical conditions. There is also too little information when it comes to psychological factors affecting other medical conditions, since it is recently added in a DSM-5, and for that, the etiology or the cause of this disorder, we have denial of the significance or severity of symptoms and poor adherence to prescribed testing and treatment. May it be denying the importance or seriousness of symptoms, denying the necessity of therapy, failure to adhere to the approved treatment plan, or failure to obtain the recommended test. It all constitutes to an individual's negative behavior and attitude that affect any disorder or symptom and making it worse. Comorbidity, by definition, the diagnosis of psychological factors affecting other medical conditions, entails a relevant psychological or behavioral syndrome or trait and a comorbid medical condition. A relevant psychological or behavioral syndrome or trait, as well as a comorbid medical illness, are required for the diagnosis of psychological factors that influence other medical conditions. Some of the medical conditions are heart disease, high blood pressure, respiratory disease, dementia, diabetes, and sensory impairment. As more information about what causes the psychophysiological disorders is found, more psychological ways to treat these medical problems have been developed and used. Some of the most common treatments are relaxation training, biofeedback, hypnosis, traditional CBT treatments, group therapy, and a mix of the above. Training to calm down. Relaxation training teaches people how to relax their muscles whenever they want to, and relaxation is often used with other psychological treatments to help people with PTSD and other anxiety disorders feel less anxious. It has also been shown to help people with physical symptoms like headaches, chronic pain, and pain from specific causes. Biofeedback is a unique type of mental health treatment in which a person is hooked up to a machine, usually a computer, that lets them keep an eye on their body's uncontrollable responses. Heart rate, galvanic skin response, breathing, muscle tension, and body temperature are just some of the things that can be measured. Biofeedback can be given in a few different ways. The first is led by the doctor. The doctor will actively lead the patient through a relaxation monologue and they will encourage the patient to relax the muscles around the area of pain or within the entire body. While the patient is listening to the monologue, the clinician can see how the patient's body is reacting in real time, and biofeedback has been supported by many research studies, especially for people with pain and headaches that don't get better with medications. It can also be done with computer programs made by psychologists. The most common is program called Wild Davine, which is now called Unite. It is an integrative relaxation program that teaches breathing techniques and measure the patient's physiological responses at the same time. This kind of programming is especially helpful for younger patients because there are different games they can play that require them to be aware of and control their thoughts, feelings, and emotions. Hypnosis. For some people say that it is just a state of extreme relaxation, but it has been shown to help reduce pain and calm anxiety caused by medical procedures. a person can learn to self-hypnotize or get recorded hypnosis monologues to help manage physical symptoms outside of hypnosis sessions by going through a lot of training. Even though more research needs to be done in the field of hypnosis, studies have shown that hypnosis is effective not only for treating chronic pain, but also for reducing anxiety, getting a better night's sleep, and improving in the overall quality of life. Group counseling or group therapy is another effective way to help the individual or help people with physical illnesses that cause emotional pain. These groups not only try to lessen the bad feeling that come with the chronic illnesses, but they also help people who are going through the same physical and mental symptoms. And most of the time, these groups are based on the cognitive behavioral therapy or CBT. They use cognitive and behavioral strategies in the group setting to help people accept their illness and deal with unhealthy ways of dealing with it. To sum it all up, for the DSM-5 diagnosis, somatic symptom disorder is excessive thought, distress, and behavior related to somatic symptoms. Illness anxiety disorder, unwarranted fears about a serious illness in the absence of any significant somatic symptoms, and the psychological factors affecting other medical condition, lack of positive coping strategies, psychological distress, or maladaptive health behaviors exacerbate physical symptoms. The other two, which are conversion disorder and factitious disorder, will be reported to you by Miss Rachel Hilario, and she will also discuss the she will also discuss other specified somatic symptom and related disorders and the unspecified somatic symptom and related disorders. For that, thank you everyone. Thank you for listening. Good day.